our next conversation is really off the theme of count us in, right? It's a powerful statement because we want to make sure that we're saying count us in, meaning everyone. And so what does it feel like when you don't feel seen? And I know that personally. So this conversation really brings that reality to the forefront. It's a fireside chat with two incredible patient advocates that you've already heard before, which is Gladys Chesumbai and Jackie Wambua. Hi, everyone, and thank you so much for tuning in and hanging out with us for our fireside chat. I am joined by some extraordinary leaders who are on the front lines of this work every single day. And as you know, the title of our conversation is No Data, No Dignity, a Global Response. We have Gladys Chesumbai, the head of the National Cancer Registry of the National Cancer Institute of Kenya, and a global certified cancer registrar. She is the one that is tasked with immense responsibility to actually building the equitable data systems that we are discussing. And next, we have Jackie Wambua, who is the leader behind the Empower Initiative, who brings the cultural perspective of public and private partnership and the on-the-ground system strengthening in Africa. Our goal in this conversation is to connect the dots between the reality of collecting data and the imperative to use that data for advanced research and care and the practical partnerships that make it possible. So I am going to start with a question that's going to be generalized. And so from a unique vantage point that confronts the reality of invisible patients every day. Gladys, you're an advocate. You're also in the front lines of, collecting data. Could you share what phrase the dignity of being counted truly means in your work?
Thank you so much, Candace, for that question and for having us today. Yeah, the true implication of being counted as a cancer patient goes all the way to policy. So when the patient is not counted from wherever they are, this just actually means that resources will not be allocated to fighting cancer in that region or in that community. So it's quite important to count all cancer cases within our communities and categorize them by age, by gender, by type, so that key decisions can be made based on the data, and that each and every cancer patient can get support through the government, in this case, government of Kenya. Yes.
So that must be immense pressure, right? I mean, you're seeing the numbers, you're seeing the data. I mean, how do you reconcile this immense responsibility of being the custodian, so to speak, of patient statistical dignity? That has to be a heavy lift.
Well, it's a lot of pressure. It's a lot of pressure knowing that resources are limited and that cancer cuts across all communities. So there's no way we can say in that community we have no cancer, that this community has more cancer than the other without actual databases. So it's immense pressure and it's immense responsibility. And I really do not take this lightly as part of my job.
That is amazing. So, Ms. Jackie, Empower. I was so amazed when I read about the program. And so that program is designed to strengthen health systems, right? From your vantage point, the work that you all have done with that initiative, why is investing in infrastructures like cancer registries a non-negotiable? and especially like a first step towards achieving equitable cancer care?
Thank you very much for asking me that question, Candace. And looking at the experience that we've had with the Empower Clinic since 2019, and bringing this collaboration between different partners who really understand the patient journey, especially when it comes to breast and cervical cancer. One of the things that I believe why it is important for us to really have data and cancer registries is because then we are able to inform policy. Because really, if we don't have anything in the registry, we are not be able to have policies that actually improve cancer management in our countries. Secondly, we also have to have proof of what we are dealing with. And I think that is what the National Cancer Registries will do for us, because they also show us the prevalence of the disease and what can we do. Because a lot of times in our countries, we are dealing with communicable diseases that have been well understood. But when you talk about non-communicable diseases like cancer, we only have to work with what's in the registry. The rest will just be hearsay or emotional conversations. But if you're really going to change treatment of cancers in our countries, then we need the registry, because then we'll be able to inform us in terms of the prevalence of the disease and even what are we financing for, especially when it comes to financing for care.
Well, you know what? And that leads right into my next question, right? When you were talking about with the registry. So, you know, when you're working between the public and private sectors, like, and when you partner with leaders like Gladys, what is the most valuable thing you can offer beyond, you know, information? Like, is it technology? Is it, you know, like, how do you collaborate and say, this is what we need, or this is, you know, what we're doing? What would a collaboration look like, you know, with someone of Gladys's leadership?
So I'm proud to say that we are already collaborating with the National Cancer Institute as the Empower Clinics. And what we've done was to bring the National Cancer Institute because it provides governance for us, especially when it comes to cancer management. And on top of that, the National Cancer Institute has been mandated to really help us understand the disease. So working together with the government, it actually provides a sustainability in the private sector. And we are having a partnership already where we have provided and supported the National Cancer Institute to come up with a platform, a digital platform that has an end-to-end perspective of the patient journey for breast and cervical cancer. And that data sits with the National Registry that sits within the National Cancer Institute. Maybe Gladys can be able to say how that experience has been working. Yes.
Would love to hear that. Yes, please.
So thank you. I was very excited when I saw Jackie here because of this partnership that we are working on. As part of my role, Candace, is not just to collect confirmed cancer cases, but also to establish a screening registry to help us know who has been screened and for what they have been screened for and what was the outcome, so that we can be able to, one, catch cancer early, because most of our cancers, based on the cancer registry data, we have found out that most of the cancer patients are coming in at stage 3 and 4 at the point of diagnosis. So the government is rolling out a lot of screening initiatives in the communities, and the Empower platform that through Jackie and her team, we have been able to enhance, is going to help us capture information on all the people who have been screened on breast and cervical cancer, and hopefully in the coming days also expand that to other cancers, including colorectal cancers. So knowing who has been screened and how they have been screened and when exactly they were screened, and if the outcome was positive or negative or whatever it was that was found out. And then for the positive cases specifically, navigating them to care, so that ensuring that someone who has been screened is linked to care, so that they are not left hanging in between, not knowing where to go. So we are really excited about this partnership with Roche and the Savannah informatics team, on the Empower platform. And this is a game changer specifically for cancer data because and screening data, because a lot of screening systems are available in the country, but all this is not is in silos, right? So that we cannot access this information to make proper decisions. So putting that together in a national system can enable better decisions, better policies, and this directly affects the cancer patient or the cancer client who has not been diagnosed yet, or who is worried about a cancer diagnosis.
And that speaks to, the human nature of being concerned about, a cancer diagnosis. That can be extremely problematic. One of our speakers that we have will talk about the challenge that in some countries, not even notifying you that you have cancer is not even something that's necessary. And I can't imagine, as a survivor myself, not being told that I had cancer, and so where's the dignity in that? They're not even mandated to. So when you think about, the human side of all of this, does that make, what you do that much more important, and not so much more important, but personal, right? Because sometimes we see things. I've always been told, what you see is what you've been called to fix. And so sometimes you can't unsee, damage or pain. And you're like, what can I do to eliminate that suffering? Does that add to more pressure? And this is a question for both of you. Does that make you, that much more empowered to do the work that you do, but also to make the case for each and every person, not only to be counted, but to have that dignity to relay that this is not just numbers, but these are people?
Yes, Candace, and as you're speaking, I'm also thinking, and I think that's why Gladys and I, what we do is about giving dignity. And if, in all honesty, we are all potential patients. So the only thing that separates us from you being healthy or sick or with a cancer is a diagnosis. So really, we have to make it personal because we don't know. And we'd have to ask ourselves, what would we want in our situation? And I think that is what we've been working together with Empower brought. It brought dignity to our patients because our patients had to travel over 400 kilometers just to get even a screening done. And by having the Empower clinics at the community level, we're providing dignity for these women because, like you've heard from Gladys, these women are coming at late stage. And to add even more to that is that the benefit of having an Empower clinic is that the men are also accompanying the women to understand and are also being screened for prostate cancer. And in that room, the woman is also educated about HPV DNA vaccination, because at the end of the day, you want to eliminate some of these cancers, especially cervical cancer. So when you ask, is it personal? Yes, it is, because we all are potential patients and would want the best of treatments, and would actually want our patients to live. Because at the end of the day, it's a life that matters. For me, I think that's why I take it personally. And collaboration is what we are looking at, because we cannot solve it as one. As a private sector, we have to bring the public sector, we have to bring governance from National Cancer Institute and the government for sustainability.
You just gave me chills with that. Because as a survivor myself, I fell through the cracks in our system here in the U.S., and I felt the pain of invisibility. I felt dehumanized because no one had empathy for me. And it wasn't until I started speaking out that I was like, okay, something is not right here. And for those patients that don't have a voice and that in spaces that can't speak out because the infrastructure is not there, right? The information is not there. The mantle for carrying, these stories are not there. So I am especially sensitive, to that. And so when you shared that, I was trying to keep myself a bit emotional because I'm like it reminds me of my own journey. And so when I hear these things, I'm just like, my God. But then we have the other piece of this too, right? And that's the patient's perspective and the lack of trust, because when you have been through a system that has not taken good care of you or hasn't seen you, you kind of lose trust or you don't have the trust. So when it comes to collecting data, and especially in communities that are not being counted anyway, what strategies have you found most effective engaging with communities to convince them that sharing, their data about their journeys, about their health, will lead to tangible benefits for them?
The National Cancer Institute perspective, one of the very effective ways of getting the patients to be seen in their journey through cancer is the use of patient navigators. We have lay navigators who could also be cancer patients. So the cancer patients themselves getting the other newly diagnosed cancer patients to seek care in form of just guiding them through the system, guiding them through the government insurance that is available, what it can do, what it can't do. We find that it's easier for a cancer patient to listen to a survivor because they're able to see themselves surviving the disease, just like the survivor. Getting the patient navigators to be kinder. And effectiveness usually is for people who have gone through the same journey. So they're able to say that, it's hard. It might look hard right now, but it's going to get better. This is what you need to do. You need insurance. You need to start paying. You need to get a support group. Here is the support group guiding them, holding their hand to be able to access whatever is available for them. Because sometimes just looking at the health system itself, it's very easy, as you have said, Candace, for a patient to fall in through the cracks because nobody sees them in the health system because it's more, technical, is more. We have so many patients who need care. So sometimes for the nurses, for the doctors to just sit down and see the patient, really see the patient and their pain, it can be a tall order. So we look at having patient navigators, both lay and professional navigators, guiding the patient from the point of entry, either for the at the screening or at point of care at diagnosis, so that the patient feels that they can call someone directly, that this person understands what they are going through. And the other aspect is just giving them a voice, as I had said previously, just getting them to speak in public forums where patients are, where other people, professionals or other survivors, or in school forums, in conferences, getting the cancer survivors to have a voice, to advocate for their rights, to speak about what they have gone through and how they came through the other side. So I think for me, patient navigation and giving the patients a voice to speak in the most relevant places is the most effective way to give them a voice.
Great. Jackie, would you like to add anything to that?
Yes, Candice. I think if there's something that we've changed, and Gladys is here to also confirm, is that the patient advocates are really critical because they're the ones who speak the hope. And they're the ones who also show that the systems can change. And system change is possible. So we have patients who have been treated. And I know, Candace, like you're explaining your personal journey, it's an experience that a lot of patients have had.
Yeah.
but there's hope because you're alive. So your story that you're alive, having a good quality of life and seeing what looked impossible for you at that moment of treatment gives another patient hope. So really what we've been doing even as Roche is working closely with patient advocates and giving the stories of hope. Patients who understand the health system and the challenges in the health system, because they also link now the patient navigators, the work closely with patient navigators, because some of the patient navigators may not be patients who really have walked through this journey. And that patient experience is so personal that sometimes we actually need a patient to speak to another patient for the patient to have hope that they can recover and provide
Wow.
them that hope, provide them the counseling. So those stories of hope that our systems also work are also what we really need to continue amplifying, bringing these patients into forums like Gladys has said, for them to share their stories, because it is possible, even within our fragmented health system, to get treated and have quality of life.
Oh my goodness, and you're so correct. It's a fragmented system, and it's and it always floors me. I always say, living in the U.S., sometimes I'm not gonna say sometimes we operate in our privilege, right? Because access is there, but in certain areas it is a challenge. But when I hear that the access that we tend to, I'll say, not really, fully appreciate when you hear the lack of access elsewhere. It's like, oh my God, what? I mean, just listening to, stories of patients not being able to, stay in the hospital because the hospital is too full, or too full, so they're sleeping on the side of the road outside of treatment. Where is the humanity in that? And I think that's what this has impacted me so in terms of this discussion. It's like, we're not just talking about numbers, we're not just talking about dignity, but we're also talking about humanity. Because, how do you communicate that humanity to people when you're saying, hey, here's what statistics say, and let's just say for funding purposes for, programs, but then you're trying to communicate that to people who have the ability to make change, but they're not listening. How do you advocate for humanity? To like, this is not about numbers. This is not about, behind this is a mom, a dad, a child. What is that like to have to navigate in that space? Oh, I see by the faces like, ooh. I could tell by the expression.
I think the space is there, and I can tell you, if having worked with some of these health systems in Africa for over 10 years, is that bringing the patient at the center of this conversation changes a lot of things, and also makes things possible that we as private sector or even public sector did not think is possible. But when the patient gives their story in all these conversations, whether it is in a policy conversation, whether we are talking about protocol and guidelines, if you have patients within those conversations, I think a lot of things change and a lot of things move in a different direction. And we've seen a lot of this change, not just even in cancer. When you look at HIV changed because patients pushed for change. And I think that's where we also need to learn when it comes to cancer, whether it's prostate cancer or whether it's breast or cervical cancer. It's having the patients being part of these conversations, because then you're not making decisions for people who are not there. You're making decisions for patients who are actually walking through the system, experiencing what you're saying, the fragmentation, experiencing the miscommunication and the delays of treatment.
You are truly the translator between the language of human suffering and the language of investment returns. That is, it's empowering for me. It is empowering for me to hear that. And so, Gladys, I'll ask you something similar. When you present, the hard or incomplete data to policymakers, and you're holding up a mirror for systemic failures, how do you find the courage to um, present that reflection? And what is the most difficult truth that you've ever had to deliver in that space?
Uh, Working as the head of the National Cancer Registry, as I said, it's quite a big burden. Most of the time we rely on the health facilities to notify that, we have a cancer case here. This is what it is, and then share that information with the National Cancer Registry. At the point of policy, and we have the politicians and, the political class here, and mostly you will find that a lot of people at that level believe that there's a lot of cancer in their communities. The hardest thing that I've ever had to do is to show the numbers and say, yes, we hear you. You feel that there's a lot of cancer cases in your community, but based on your data and the data that the health facilities from your area are notifying us on, then we don't believe there's that much data. There's that much cancer unless there's underreporting. Okay, because then as the National Cancer Registry, we have to rely on proof that is available. We have to rely on other bodies, other facilities to notify us. We do our bit by training them, by ensuring that we follow them up. Therefore, at the point of policy and the point of defending the data, we have to say that this is what we have. As per the data that we have, your cases are not 1 million cases. They're just 2 cases, for example. And that is a hard thing to say, especially knowing that, yes, we are actually underreporting, or it's possible that some cancer cases are not being captured at the point of histology, which is what the health facilities are reporting. That's why we advocate for population-based cancer registration, where we are not just looking at histological diagnosis. We are looking at all other forms of diagnosis that are usually not acceptable at the point of as a gold standard for diagnosis, morphological diagnosis. So we need to go to all areas within the communities to figure out who could be having cancers, what kind of care have they accessed, and why is it that they're not getting histology. We found out that it could be a cost issue, where the patient does not have enough money to be able to access histology. They could fear surgery. We have a lot of myths and misconceptions here, where one of them is that a patient, once you have a tumor and you get surgery for it, then the cancer will really spread really fast. So you find that a patient has the resources to do surgery, but they will not do it because of that misconception. Some of the patients also prefer to use traditional means of treatment or even diagnosis. So they go to the traditional healers and they have a mass, and a lot of things is done on the mass, and they don't usually show up at the health system. Okay, so I know for sure that we are not counting all cancer cases. But at the point of policy, I cannot use assumptions to say that, I assume that we have this number of cancer cases. I can only use the confirmed cases that have been shared with us. So that is the hardest thing that I have to do as the head of the cancer registry, knowing that we are not capturing all cancers in our community and having to justify why we need to do population-based cancer registries in the midst of very little resources within the country.
So with that being said, so, some of our, our audience members, they're like, they are NGOs, they're community health workers, or, they are trying to do their part in, and just don't know how to do that? Or like, how do we get data back to, the Ministry of the Health or to Cancer Registry? Is there any advice, especially in areas of, where there's poor internet connectivity, or like, what are the most effective low-tech ways that data can be recorded? Because I do know in some areas we've discussed before that are still collecting health information on paper. But is there anything that our audience who are in the trenches, but they don't have the infrastructure to connect to, online connectivity or to be able to transmit data back? What Any advice that you can share, either of you can share, and because I know that Jackie, the Empower Project is about that very thing, but from a registry perspective, Gladys, what would be helpful?
So in Kenya, we still utilize paper-based record keeping practices, but with the web-based systems that we're utilizing at the National Cancer Registry, we have offline capacity so that the data collectors can use the system, the NACARE system, the National Cancer Registry system, even where they don't have internet, so that when they are able to access the internet or network, they can be able to upload this information to the larger web-based system. So that's what we think can help, although we still have issues with internet connectivity and network in some parts of the country, and also the cost of using daily internet can be a bit high, and therefore those are the areas that we find challenging at this point, where we are utilizing a web-based system and the internet issues are still arising and challenges are still arising. So one of the areas, and in terms of the general response to that, is that we try to ensure that the facilities that support us in terms of data entries and things like that have internet already, although even them, they have downtimes and uptime sometimes. So the challenges of network emerge now where we're using web-based system, as opposed to when we had to just use a pen and paper, write, and then sit down and enter this information.
Because this is very important, and the project that I bring it back to Empower, because it's such a great model, and so for our audience, many of our audience members would like to pilot a success program like that. So based on the Empower model, what is the key to scaling a local data solution to a regional or national level without losing the effectiveness?
That's a good question. Maybe I can start and then allow Gladys, because she may be the expert, but I'll look at it from the Empower program. And one of the ways that we have been able to collect data is by integration. And I think integration into what is already existing, so that we're not running parallel data points. So our Empower clinics are within the primary healthcare system. So it's integration of breast and cervical cancer screening in the primary healthcare system. But within the primary healthcare system, there's also what is working and what is efficient, using those models to bring in our data point for collecting data for breast and cervical cancer. So integration, and I think also using simple digital platforms that can be used very easily by the nurse, because remember, we're also not resourced very well in our primary healthcare system. Can the nurse be able to input the data for hypertension, diabetes, and breast and cervical cancer into one tool? So the integration, I think, has simplified a lot of our processes. Maybe Gladys, you can add a point.
Yeah, and so I think, yes, integration is one of the key approaches that we are looking at, but also just doing an assessment about what is being used I mentioned that we have a lot of silos, a lot of programs in the facilities, all doing more or less the same thing. So doing an assessment of what this facility or this community is using for their data capture, and being able to see how can that be able to work with what we have. Now, being government and the National Cancer Institute, it's quite easy to get the facilities to adopt the Empower system. So looking at them as stakeholders and bringing them together to show them, to showcase this system and what it can do for them so that we can get buy-in from them is one of the critical start points that we must do. So because some facilities are already using Empower, others are still not using it. So just getting them together, showcasing what Empower can do for them, showcasing the dashboards and the reporting structures and how simplified the data management can be using Empower, and just integrating that to the National Cancer Registry system so that when the patients are screened, their information can be linked to the National Cancer Registry in the long run. So looking at these systems that we have in the long term, looking at them as systems that will outgrow us, looking at them as systems that will be here 100 years, 200 years from now, that can be upgraded, that can be integrated to other systems that are already in use in the system, that can interoperate generally. I think that is our biggest success, and that is our biggest goal. So I'm excited about the Empower system and the platform and how that can integrate with NACARE and other systems so that we are able to get what we need without necessarily by working and partnering with other partners in the country.
So that is, so one of the things that key things I keep hearing are about community health workers and that, the importance of, that trust, that person being in there. So, and this will be, one of my last questions. I do have one other question that I want to ask, a UNICEF question, but what advice, because because we have so many people that are like, how do we do this? How can we help? How can we collect? Because we know people aren't being counted. So I would say, like, as a first step, what advice to our audience would you give for how to approach hard to reach community to begin the conversations about cancer data collection in a way that's respectful, ethical, but also builds that genuine partnership? Is there anything that we haven't talked about that would assist our audience in doing this?
Well, also basing this on the National Cancer Institute approach, community awareness programs, community sensitization programs, where experts can go to those far-flung communities to educate them about cancer, make them aware that there's something called cancer, that what you're seeing here is not just witchcraft, for example, that this is a disease that has a name, that there's care that is available. So the National Cancer Institute has put in place a lot of community engagements, a lot of community screening programs, especially for the marginalized communities, so that we leave our headquarters in Nairobi and go to Turkana, for example, and here these are about 700 kilometers from the nearest health facilities that they can go to. So we go there, we go there with other partners within surrounding communities to sensitize the community, to screen them, and to set up oncology centers in those communities by getting qualified oncologists to sit there, even if it is once or twice a week, to set up clinics where patients can be going for chemo, can be going for consultation, they can be going for different sorts of care. Yeah. So as a National Cancer Institute, we put forward the needs of the patients through education, through awareness, and putting foremost the need for diagnosis. getting a diagnosis is the first point. As Jackie had mentioned, having that diagnosis enables you to get treatment because you can now have a confirmed disease that has been, that has a name, has a stage, has a specific, cell type that can be looked at. So as a National Cancer Institute, this is what we do. And we have done that in different communities, including those extremely marginalized communities in Turkana, in Samburu, those pastoralist communities. We have gone to Lamu, we have gone to Kwale, those coastal communities that are marginalized, just to ensure that everybody's voice is heard, that everybody knows that they're important to us as the National Cancer Institute, because our business is to ensure that we lead the response towards cancer care in the country.
And speaking of cancer care, right? So there's a challenge too, right, with cancer care. So if you're having the challenge with cancer care, you're also having the challenge with clinical trials. So, and that was, one of the, the issues, that Dr. Ibrahim talks about from aortic is that she brings clinical trials to Africa as a way of treatment because they are not treatment options. And so you just expound more exactly on what that challenge is. And then when you talked about the stigma, I was floored when I heard about the stigmas of witchcraft and the challenges of women not wanting to seek treatment because of fear of not obtaining a husband or things of that nature. That is so, it's like, oh my God. So you're gonna forego any type of treatment, because of, and we here in the US, we're always saying fear, right? But this is a whole nother level that it's like, oh my God. So the work that you're doing is so imperative and so important. But it also gives hope. I think, listening to you, I'm hoping that the audience is taking notes and is realizing that you're actually giving them the blueprint, to help in their communities with this. And so I'll ask one last question, before, I'll let everybody go. If our audience members wanted to start a program or a pilot or any type of way that would help move the needle forward in their community, what is the call to action? What is the advice on, just one piece of advice? And then what is a call to action, for our audience? Like, okay, and I'll just say, like, what would that be in terms of, like, okay, you know what? Step out. If it's fear, step beyond the fear. If it's funding, don't let funding keep you from, not doing something. There's always ways to do something. So I'll shut up because I can keep going.
I'm thinking about it's a very good question and a very good way to conclude. If I would take one point, would be let us not reinvent the wheel. Because something is working in those health systems. Let us go to those health systems that are working. The community engagement also, there's something the community that's working in the community. So we are not going to reinvent the wheel. And that is one thing that I learned together with our team through the Empower program. We are not reinventing the wheel. We are going to understand. The community already understands dynamics. The community also has a way of communicating. Then how do we link the community engagement to this health system? That within the health system, let us look for what is already working. I think we always go with the challenge and make so much talk about the problem rather than see what is already working. So we are not reinventing the wheel. We are coming to integrate and complement what is already working. Because those networks exist that you've heard from Gladys, both at the community level and the health system level.
So what would you tell them?
So I would tell them, once you don't reinvent the wheel, I think put the patient at the center of that conversation. So that you're not making decision in isolation. If you're talking about a cancer patient, bring the cancer patient to give you the experience. There's no better place to learn than the actual experience of the patient. I think for me, that's what I would really say. And say it is possible because we've done it. And you can hear that we are talking with the government and it's already working. Serving the community and serving the patient, which is most critical really for your success if you're going to use data to inform your policies.
Right. That was powerful. And don't reinvent the wheel. I love it. I absolutely love it. Good. Miss Gladys?
So, what I would say is that despite the numbers, the high numbers that we're seeing in terms of incidence, in terms of mortality, in terms of prevalence of cancer, each of those numbers represent a family, it represents a person who has their life, who is a mother, it could be a father, it could be a child, someone who is just like us, who is working, who is stay-at-home mom, for example, or they are a high achiever of whatever, in whatever area they are in. So counting each cancer case is important, but how do we do that? How do we count? Patients can help in counting the cancer cases. All this time we've been talking about the health system and how we collect data at the point of diagnosis or at the point of care. What we are not exploiting and what we are not currently using is patient-led cancer registration, where the patient themselves are able to say, this is me, my name is Gladys, and this is my age, this is my residence, and this is the kind of cancer I have been diagnosed with, this is how I was diagnosed, and this is the kind of treatment that I have received, this is the kind of experience that I have been able to receive, this is the kind of stigma that I have been able to see, and this is how I feel about all this. A patient-led cancer registration practice, and that is what I'm trying to push for, because there's a lot of inaccuracy even at the point of collection where the patient, as Jackie has said, is not involved. But if we can get the patients to understand why this is important, to count each case, to get very accurate information, a patient-led system of cancer registration, that can really help us in terms of accuracy. It can help us to understand the health system better. It can help us to plan. It can help us to target specific voices for specific platforms, patient-led cancer registration. Also, not forgetting that, other forms of cancer registration that are utilized, including hospital-based cancer registration, pathology-based cancer registration, and population-based cancer registration are equally important in capturing those who might not be able to give their own information, but having an approach where the patient themselves are able to say that I want to be fully involved in the way my information is used and how this information can inform policy. I think that is the future of cancer registration practice. Back to you, Candace. Thank you.
Thank you so much. You all have given some powerful information, and you have lent your voices to what this is, what we all perceive as a huge global problem. I think you have given some amazing advice, heartbreaking to have to discuss this. But it's like, how do we not have this conversation? How are we human beings in this world and we don't have this conversation globally? And so I think that the response has to be global. It has to be together. It has to be, how can we work together to improve our lives? Because it is a system. This world is large. It turns. And so just like the tide turns, it might be, US today, it could be somewhere else tomorrow. It could be, wherever that is tomorrow and somewhere else. And if we don't collectively tackle this problem, we'll continue to repeat it and it'll get worse. I definitely want to thank you. And I just want to give a quick synthesis to what we discussed. And it's the path to equity is a chain of links with meticulous work within registries. It is community health workers. It is overcoming stigma. It is the patient voice. It is also not reinventing the wheel. It is an ambitious global research, and it is enabling the power of strategic partnerships. And if one link is broken, the entire system is failing. So, your insights have made it clear that counting every patient is not merely technical, it is the fundamental act of justice upon which we are all in this together, and the progress depends on us all. So, to our audience, let the message from this conversation be your call to action. Demand better data, support the registries, fund partnerships, champion research, because when we decide that everyone counts, we are making a profound choice to care for everyone. Thank you so much for listening. And thank you so much, ladies, for joining us and, and giving us your professional and personal heart, and advice on this matter.
Thank you very much for having
So
us.
much, Candace.
Thank you. And thank you all for tuning in, and we'll see you in the next session. That was amazing. I so enjoyed talking to those ladies. I could have continued on and on and on, but we would never move on to the rest of the day. So I want to thank Gladys and Jackie for sharing, their insights with our audience and for bringing humanity to the work of data and innovation. And they've reminded us of disruption without dignity isn't progress, it's noise. So thank you again. So it's poll time. I think I need some pom-poms. So what is the greatest barrier to cancer registration in your area? And so we know that this is not happening everywhere. So this is a pulse check for us. And this is a pulse check that we can share with you later. But we want to know, like, what's missing? Where is it? Where is it not? Where is it? And who's able to access? So we'll give you 15 more seconds. And thank you again for being an active participant for our Congress. As I said, it is interactive and we want to continue this conversation. Ooh, this is very interesting. Lack of technology, fragmented information and resources. Wow. And 28%. Reluctance for patient participant. And that's huge too, right? Because when patients are not participating, it's not usually because they don't want to, it's probably because they don't know and information is not being given to them. So thank you so much for sharing that and for sharing this poll.